Hello everyone, welcome to the Smart RN channel and thank you for logging in. My name is Henry. Today we continue with our series on infectious respiratory diseases, and in this video we are looking at tuberculosis or TB. Tuberculosis is a potentially life-threatening respiratory infection which is caused by a bacteria known as Mycobacterium tuberculosis. This bacteria is an acid-fast bacillus. In other words, it is that bacteria that has the capability to retain its original color when stained or washed in an acidic solution. TB is spread via aerosolized droplets. These are very tiny and light droplets which are normally released into the air by an infected person when he or she sneezes, coughs, talks, or even sings. Now, these particles are so light and tiny such that they can remain suspended in air for several hours. Now, a person becomes infected when he inhales these tiny droplets that are containing this bacteria. And when a person inhales these droplets, there are three things that can happen. One, the bacteria could be destroyed in the upper respiratory tract or in the alveoli. So when this bacteria is inhaled in, it enters the respiratory tract. Remember, when we are talking about the respiratory tract, we talked about defense mechanisms. There are a number of defense mechanisms in the upper respiratory tract that help us to fight against pathogens. For example, we have the mucous membranes that release mucus that traps these pathogens. We also have the cilia. The cilia normally initiates the mucociliary movement, which helps to move these particles from our respiratory tract towards the outside for expectoration. So when this bacteria enters into the respiratory tract, it could be destroyed by those defense mechanisms in the upper respiratory tract. Now, sometimes this bacteria can evade these defense mechanisms and land in alveoli. In the alveoli, we said that we have got what we call macrophages. These are cells that destroy bacteria using a process known as phagocytosis. In other words, they engulf this bacteria. So if this bacteria lands in the alveoli, it could actually be destroyed by the macrophages via phagocytosis. So one thing that could happen with this bacteria once in the respiratory tract is that it could be destroyed by the upper respiratory tract defense mechanisms, or it could evade them and go into the alveoli where it is destroyed by the macrophages via phagocytosis. Another thing that could happen is that once in the lungs, this bacteria could be surrounded by white blood cells to form what we call granulomas. A granuloma is a white blood cell cluster. It is a cluster of white blood cells which are surrounding and enclosing pathogen. So this bacteria could be enclosed by white blood cells in these granulomas, resulting in this bacteria becoming dormant. So sometimes we have this bacteria in our bodies, but because it has been surrounded by the white blood cell, it is dormant. It is not able to multiply or spread to other parts of the body. But remember, this method will only be effective as long as the immune of that person is intact. If the immune remains intact, this bacteria can remain dormant in the body of this person for the rest of his or her life. In other words, the bacteria can stay in this body without breaking out to cause active TB disease, so long as the immune system remains intact. And then this bacteria could also break out into active TB. Once this bacteria lands in the respiratory tract and goes all the way to the lung, it could start to multiply and spread to cause disease or active disease in that particular person. So those are the three things that could actually happen when a person inhales those tiny and light droplets containing the tuberculosis bacteria. So what are the risk factors that can expose us to tuberculosis? One, we have got crowded environments. Those people who are working or living in crowded conditions, they can contract the bacteria that causes TB. For example, nursing homes, we have got prisons, we have got homeless shelter, whereby there are so many people staying in close proximity to one another. Then we have exposure to active TB. If you come into contact with a patient who has active TB, you stand a chance of contracting that bacteria. For example, the family members of that patient with active TB, because they spend longer time or long hours in close proximity to that patient, then they stand a chance of contracting the bacteria. We have immunocompromised people. These are people whose immune system is very weak for one reason or the other. For example, we have HIV or AIDS patients. The immune system is compromised. We have cancer patients who are undergoing chemotherapy. Those drugs normally weaken the immune system. We have organ transplant patients. Remember, in this patient, the immune system is normally suppressed so that the organs cannot be rejected by their bodies. So these people have got a weaker immune system that exposes them to the bacteria that causes tuberculosis. We have those people who have been prescribed long-term steroids. They are taking long-term steroids for one reason or the other. These steroids normally weaken their immune system. So those people with an immune that is compromised stand a chance of getting the bacteria that causes TB. We also have those patients with chronic diseases. These are patients who are having diseases like diabetes, who have got kidney disease for a longer time. This patient can contract the bacteria that causes TB. And then we have those patients with malnutrition and low body weight. That's another risk factor that exposes them to this particular TB bacteria. Now, how do we classify tuberculosis? Tuberculosis can be classified in a number of ways. One, we have got primary TB. This is the first stage of infection when the bacteria enters the body of that patient. Now, we have just said that when the bacteria is inhaled in via the tiny and light droplets, three things can happen. Either it is destroyed in the upper respiratory tract by the defense mechanism, or it is destroyed in the alveoli by macrophages via phagocytosis, or it could become latent TB, it could become dormant. That means it is captured and surrounded by white blood cells in the granulomas, making it dormant, or it could break into active TB. But that first stage, when this bacteria enters into a patient, it is referred to as a primary stage. In this stage, the patients are asymptomatic. They don't have any symptoms for TB. Number two, they cannot spread that bacteria. They are not contagious. So primary stage is where the patients are asymptomatic and also they are not contagious. Then number two, we can classify TB as latent TB. Now, this is where the white blood cells have formed granulomas. They have surrounded this bacteria, making it dormant. It does not have the capability to multiply and spread to other areas of the body. So latent TB is where the bacteria is dormant because it's surrounded by the white blood cells. But remember, we say this can only happen as long as the immune system is intact. Whenever the immune system remains intact, then this bacteria can remain dormant for the rest of the life of this particular patient. The third classification of TB is active TB. This is when the bacteria multiplies and spreads in the body to cause disease. Normally, TB affects the lungs. In most cases, the TB affects the lungs and refer to it as pulmonary TB. But there are other cases where the TB spreads to other parts of the body to cause disease in those areas. That is extra pulmonary TB. For example, this bacteria can spread to the spine, to the brain, to the bone and joints, to the liver, to the kidneys, to the heart muscles, and cause disease in those particular areas. So active TB is when the bacteria multiplies and spreads in the body, causing disease. The fourth classification is drug-resistant TB. Now, this is TB where the drugs can no longer kill the bacteria. These are drugs that once killed the bacteria, but now it has come to a stage whereby those drugs can no longer kill that bacteria. And this is normally due to a number of reasons. For example, when patients don't take the drugs or the antibiotics as prescribed, sometimes they take the antibiotics and when they feel better, they stop taking. They don't complete the dose. This is dangerous because it can lead to drug-resistant TB. We also have genetic changes in the bacteria itself. There are genetic changes that may take place in the bacteria over a long period of time, making it be able to withstand or to resist the drugs that once used to kill it. So when that happens, we have drug-resistant TB. Sometimes the patients are also prescribed wrong medications. When they are prescribed wrong medications, that could result in drug-resistant TB. We also have poor quality drugs. So when you have drugs that can no longer fight this bacteria, then the TB can become drug-resistant TB. So those are the 4 classifications of TB. Now, what are the signs and symptoms of TB in a patient? When a patient has TB, a number of signs are evident in this patient. One, we have got fever. Remember, fever is a hallmark of any infection, elevated temperatures. So these patients are going to have fever. Then they also have pain. And this pain is going to be in the chest. These patients start feeling pain in the chest. And sometimes they feel this pain whenever they breathe or they cough. So there is pain in the chest or pain when breathing and coughing. We also have a cough. That's another hallmark of this particular patient. They have a cough. And this cough can either be dry or it can be productive. When this cough is productive, they produce very thick mucus or blood-tinged mucus. Now, that mucus with the blood traces is because the lung parenchyma is being destroyed by the bacteria. So they cough blood. So they have a cough which can either be dry or which can be productive. These patients have got night sweats. They experience sweating at night. They also have got chills. They have got weight loss. That's another sign of TB. The patients lose their weight unintentionally. So that's another sign of TB in those patients. Then we have got no appetite. That's another sign and symptom in this particular patient. They don't want to eat food or they don't have that appetite of eating anything. Then when that goes on, TB patients develop dyspnea and then they also develop orthopnea. So these are the signs and symptoms that can become evident in those patients who have got TB. Now let us look at the safety aspect. Whenever a person is suspected to have tuberculosis, or whenever a person has been diagnosed with the tuberculosis, there are safety measures that must be put into place. Number 1, we have isolation. This is the priority. This is the first measure that should be initiated the moment a person is suspected of having TB or has been diagnosed with TB. Now, these people are normally isolated in private rooms, and those rooms have got negative air pressure. Now, the air pressure inside is lower than the air pressure outside. Air can easily move in, but for it to come out, it normally comes out through set points and also it is filtered. Now, these negative pressure rooms have got air exchanges of at least 12 air exchanges per hour. So the priority, the most important thing that you must do first, the first thing to be done is for these patients to be isolated. That is the priority. And then after they have been isolated, we normally initiate airborne precautions. These are precautions which are observed by nurses when they enter or when they come into close proximity with these patients. So what are these precautions? 1, nurses must observe hand hygiene. They must wash their hands when they get in and when they get out of this room. Number 2, they must don gowns. They must put on gowns when they come into the room of this patient. They also need a mask or a respirator. And here comes the N95. This is where these healthcare workers must put on an N95. And remember, an N95 has to be fitted. You have to put on the right size of N95 when you go into this room with airborne precaution. You may also need a face mask or even goggles while in that room. So airborne precautions are normally initiated whenever we are treating this particular patient. Now for visitors need a surgical mask. They need to put on a surgical mask whenever they enter the room of this patient. And in most cases, we normally restrict the number of visitors into the room up to a maximum of 2 at a time. And then another safety precaution is that we normally limit the patient movement. This patient is not allowed to get out of the room or is not allowed to walk in the hall. The patient movements are limited. Then if this patient has to go out for any reason, for example, for other procedures like CT scan, he needs to put on a surgical mask. So the patient movement outside the room is very, very limited. How do we diagnose tuberculosis? We diagnose tuberculosis in a number of ways, or there are things that we do to help us diagnose tuberculosis. One, we have a skin test. A tuberculosis skin test is sometimes referred to as a PPD test. This is a purified protein derivative, or we refer to it as the Mantoux test, or a tuberculin test. Now, this is a test whereby a very small amount of a substance called tuberculin is injected under the skin. And we normally inject about 0.1 ml of this substance under the skin. And when this substance is injected under skin, a wheal or a bump normally forms in that area. A wheal or a light colored bump will always form in that area where we inject the tuberculin. In most cases, we normally inject it in the lower part of the forearm. These patients are normally asked to come back after 48 to 72 hours. And when they come back, a healthcare professional is going to read and interpret the reaction at the site of tuberculin injection. So these patients with their skin test normally have 2 visits to the healthcare provider. One, when they come to have the tuberculin injection, and 2, when they come back after 48 to 72 hours to have that particular area read and interpreted. Now, what normally happens is that when we have a positive reaction to this skin test, we normally have an induration or a swelling or a hardened area in that place where the tuberculin was injected. Remember, when they injected it, they had to circle it or they mark that area. So when they come back, if you have reacted positively to that tuberculin injection, we are going to have a hardened area or an induration, a raised area where the tuberculin was injected. And that is a positive reaction. So the healthcare provider is going to measure the width of that induration in millimeters and offer best interpretation. One thing I want you to note is that those people who receive the BCG vaccine, they will always have a positive reaction to the skin test. These are people who receive a BCG vaccine that protects children against tuberculosis, and especially in third world countries. Those people will always have a positive reaction to the skin test. Now, when you come to the healthcare provider after 48 hours, now he's going to measure the width of that induration or that hardened area. And based on the width of that induration and your condition, he's going to offer the interpretation. And this is the interpretation. We might have an induration of greater than or equal to 5 millimeters being positive in some people. Others will be positive if the induration is greater than or equal to 10 millimeters, and others will be positive if it is more than 15 millimeters. The following people will be considered positive if the induration is greater than or equal to 5 millimeters. One, we have the immunocompromised people, those patients with HIV, those patients with AIDS, the cancer patients undergoing chemotherapy. We also have those people who have got organ transplant. If their induration is greater than or equal to 5 millimeters, it is considered positive. We also have those people who have come into close proximity with active TB patient. If your induration is more than 5 millimeters, then you'll be positive. The following people will be positive if the duration is greater than or equal to 10 millimeters. 1. Those people who are working or living in crowded conditions, nursing home residents, homeless shelter residents. We also have prisoners. We also have the healthcare workers who are working in these crowded areas. If the duration is greater than or equal to 10 millimeters, then they are considered positive. And then anybody who is greater than or equal to 15 millimeters is positive. It doesn't matter your condition. Anybody who is just 15 millimeters or more, you are positive. Whether you are immunocompromised or not, you are positive whenever the duration is 15 millimeters or more. Another way to test for TB is by having a blood test. We normally have blood tests so that we can test for TB, IGRAs. Those are blood tests where we look for the TB bacteria in our blood. For example, we have the quantiferon TB Gold Plus test. We also have the T-spot TB test. Those are blood tests which can be used to diagnose for TB. But let me make this clear that a positive skin test or a positive blood test does not diagnose TB. On their own, positive skin tests and positive blood tests do not diagnose TB. More tests have to be done to confirm TB. And that's when X-rays come in. When we have an X-ray taken of a person who has, for example, tested positive for skin test, if there are patchy areas in their lungs, if the X-ray can show patchy areas in their lungs, then those people are having active TB. So if you have a positive skin test, you must have an X-ray. If your X-ray comes out clearly, then probably you only have latent TB. Remember, a positive outcome simply means that your body was once exposed to a TB bacteria. And remember, we say that the TB bacteria could be in your body, but it's actually being taken care of by the white blood cells in those granulomas. So a positive skin test or a positive blood test only means that your body was once exposed to a TB bacteria. Then we also have the mucus. Remember, we said that one of the hallmarks of these people with TB is that they cough, and their cough could be productive, whereby they produce very thick mucus that could also be blood thin. So this mucus is normally collected and exposed to tests. For example, we can expose it to an acid-fast bacillus test. Remember, we say that when this bacteria is washed in an acidic solution, they retain their color. So we can smear this mucus with an acidic solution, and we can see bacteria in that solution with their color. Then that's an acid-fast bacillus, and that confirms that these people have got active TB. And then we can also culture this mucus. We put this mucus in a dish, and then we provide the growth medium to see what bacteria is going to grow in that mucus. So if we have the Mycobacterium tuberculosis bacteria growing in that culture, then these people have got a positive or they have got active TB. So those are the ways in which we can diagnose TB. But always remember, a positive skin test and a positive blood test are not diagnoses for TB. They only means that your body was exposed to TB bacteria. But then we must do more tests like X-rays and cultures to be able to confirm that you have got active TB. So let us look at the nursing interventions. There are a number of things that nurses do when they care for the TB patients. One is assessment. Remember, assessment is where nurses collect data that guides their intervention. Now, in this TB patient, you realize that they have got elevated temperature, they have got decreased oxygen saturation, and you also discover that they could also have adventitious sounds like rails when you listen to their lung with a stethoscope. So nurses normally carry out assessment in this patient as they continue to collect data that guides their intervention. We also have isolation. Nurses normally initiate isolation for patients who have been diagnosed with TB or those who are suspected to be having TB, patients who are under observation. So these patients are normally isolated. Now, these isolation measures are normally put in place when the patients are put in a negative pressure room. Remember, they are put in private rooms with negative pressure. The nurses also carry out the PPD test. It is the nurses who normally inject that tuberculin under the skin, and when they inject that tuberculin, they mark off that area so that a healthcare provider can read it off after 48 hours. Nurses do specimen collection. You collect the mucus. You also collect the blood when you want to carry out a blood test on this patient. Now, something about just the mucus. Just note that this mucus is mostly collected early in the morning, and you collect it on 3 consecutive days. If you want to collect for a mucus in this patient, you do it early in the morning, and you also collect it on 3 consecutive days. And then we administer humidified oxygen. Remember, we said that when we assess this patient, we could find a decreased oxygen saturation. So we administer humidified oxygen to supplement that particular oxygen. We administer antibiotics. Antibiotics are the medication that treat this tuberculosis. So we have to administer these antibiotics. And administering these antibiotics is very important that it be done on time and in correct doses. So nurses administer antibiotics. And then we provide teaching. Teaching is one of those things that nurses do, especially to the patients and their families. For these patients with TB, you teach them hand hygiene, to wash their hands, because hand washing is one of the simplest methods that can keep pathogens at bay. We also teach them about the cough etiquette, how they should cough. They should cover their mouths when they are coughing, or they should cough in tissue. And once they have coughed in tissue, they should dispose it off immediately and appropriately. We also teach them about the importance of taking medication. And antibiotic, it is very important for these patients to take the medications as prescribed. They should complete their doses. So as a nurse, you are teaching this patient that they should complete their medications, even if they feel better after just starting to take it. They should go all the way and complete all those medications. And it's also very important that they take those medications on time. We also teach them about the signs and symptoms to look for. Now, signs like, for example, chest pain, signs like shortness of breath, signs like coughing, they should look for those signs, night sweats, and losing weight unintentionally. When they see those kind of signs, then we teach them that they should be able to go to the healthcare provider, or they should be able to seek help. So those are the teaching points that nurses normally undertake when they are teaching this particular patient. And remember, especially the medication. Medication, for example, these TB patients could take medication for longer periods, for example, between 6 to 12 months. So it is very important they take the medications on time, they complete their doses, and because of that compliance, then they can be able to get rid of this particular bacteria. But remember, if they don't do that, then we end up having drug-resistant TB, which becomes even more difficult to treat. So that brings us to the end of this video on tuberculosis and the nursing intervention. As always, I request you to drop a comment, like this video, share this video, and if you are not a subscriber to this channel, please subscribe to the Smart RN channel. From me here, it is a goodbye.